Good morning, everyone, and welcome to the 22nd Annual Healthcare Symposium at the David Geffen School of Medicine. My name is Tristan Howard, and I'm a second-year medical student here and one of four co-directors for this morning's event. On behalf of Marissa, Pamela, and Samantha, we would like to welcome you to today's occasion. The Healthcare Symposium is a Dean's Office-sponsored event put on entirely by medical students that aims to explore that aims to intersect healthcare with a current matter that isn't readily linked with the medical field. Our search began for a topic last August, as we brainstormed a number of issues we thought the greater UCLA community would find engaging. After weeks of deliberation, and with input from our board of advisors, and classmates, we settled on the topic of gentrification. Gentrification is a very polarizing issue. To some, it's a welcome, necessary change. To others, it's a movement that further divides classes and eliminates communities. And to the remainder, it's somewhere in between. No matter which side of the debate you find yourself on, we believe there is no denying gentrification has an impact on healthcare of today and tomorrow. As such, we've arranged for topical speakers to explore the subject from three different perspectives in a keynote who provide potential solutions to the questions many of us have. Again, thank you to all of our speakers for being here this morning. I would like to take this time to introduce our Vice Dean, Dr. Braddock, whose input and guidance has been instrumental throughout the symposium planning process. He has willingly met with us on multiple occasions and has always been eager to help us with anything we needed to ensure today was a success. We can't say thank you enough. Without further ado, we will first hear a welcome from Dr. Braddock, immediately followed by a symposium introduction by Ms. Sarah Smith.
Thank you. Thank you, Tristan. Good morning, everyone, and welcome to the David Geffen School of Medicine and to the 22nd Healthcare Symposium. I'm just going to make a few remarks to kind of frame our day, but first I want to just take another moment to thank our four fabulous conference organizers. Please join me in giving them another round of applause. So, why do we have a healthcare symposium? As Tristan said, it's an opportunity to engage a broad community of the medical school and beyond, our colleagues in other health profession schools across the campus and across the community, in a conversation to advance our thinking in an important area that affects health. More broadly, it's really about the following concept: informed civic engagement. Informed civic engagement. Now, universities like UCLA educate young people in undergraduate, graduate, and professional degrees, certainly to provide them the foundation of knowledge and skills to enter into a career that spans the course of their lives. But more importantly, universities exist to help us begin to think and to be prepared to be informed and engaged in civic matters. That's more important now than probably at any time in any of our lifetimes. So, informed civic engagement. What does informed civic engagement look like? It looks like coming to a conference like this and being prepared to have our thinking on a topic like gentrification informed by experts, informed by dialogue with our colleagues, but importantly, informed civic engagement isn't simply coming to a conference like this and listening to erudite comments about the nature of the field and the nature of thinking, but it's what we do beyond today. And I think our keynote speaker will help us to begin to think about when we leave today to go out into the world, to return to our day jobs or our studies or what have you, how can we engage in an informed way in civic matters around gentrification? So I hope that you find today informative, stimulating, and will join in this notion that for all of us, it's a responsibility to be engaged in these matters. I think about this with the medical school. So, of course, the medical school, we're training physicians to become outstanding physicians practicing high-quality, evidence-based, patient-centered medical care. But we also expect our students to step out into the world and take their knowledge and the responsibility that comes with that and exercise it. So for example, I find it disappointing that if you look at surveys of physicians around the simple civic engagement act of voting, less than 50% of physicians vote regularly. Less than 50%. I find that unacceptable. And I would turn to my colleagues in other health professions. I don't know the data there, but I encourage you to look at that and ask the question, at a minimum, every physician, I'm speaking of physicians, every physician should be engaging in elections in every cycle of every national, state, local, in an informed way. That's a foundation. There are other ways in which physicians can be engaged in an informed way in civic matters. And I'll tell you a brief story. A colleague of mine who is now the CEO of the American Board of Pediatrics was a pediatric intensivist practicing in Baltimore at Johns Hopkins. One year in the intensive care unit, they had a particularly strong rash of severe burns to young children. It was very devastating for the staff, the trauma, for the families, certainly. And he began to wonder, why are there so many burns this winter? To make a long story short, what he discovered was that it was a particularly cold winter, and many of the families of these child burn victims were low income and had faced the following situation. Short on money, unable to pay all their bills, they had not paid their utility bill. And as a result, went to other means to try to heat their homes, and you can imagine what happens from there. So Dr. Nichols, my colleague, didn't stop there. It wasn't sufficient to merely treat the burns of these children and try to heal them and their families. He began to find out what the source of this was. And over many years of advocacy, trying to battle red tape and whatnot, he and other physicians led some new regulations of the Utility Commission that prohibited the utilities from shutting off utilities without a more prolonged grace period, enabling families to scramble to cover that. I share that story because it's an example of civic engagement in an informed way. So as we think about the topic today, we're going to delve into it and understand it. We're understanding it so that we can step outside the halls of this building and in an informed way engage in advocacy and having our voices heard and how we actually bring about change. With that, it's my pleasure to turn the podium over to Sarah Jane for her opening remarks. Thank you very much.
Good morning, everyone. My name is Sarah Jane Smith, and I'm a recent alum of UCLA. I graduated in June with my dual master's in public health and my master's in Latin American studies. And I'm thrilled to be here with you all today as we discuss gentrification in health, what I consider to be a critically important and timely topic. So I was given a few minutes to be with you here today and define gentrification, discuss the impact that it has on health, as well as the role that public health professionals and healthcare providers can play in addressing it. So over the last century on a national scale, many policies and practices have created racialized patterns of disinvestment in cities that have left low income, primarily communities of color, vulnerable to gentrification. Therefore, when we think about gentrification, it must be understood in the context of the historical backdrop of racist and classist practices, such as redlining, white flight, urban renewal, disinvestment, subprime lending, and the foreclosure crisis. So on the ground, gentrification may look a few different ways. We can think about it in terms of real estate speculation, so investors flipping properties at a large profit, landlords looking for higher paying tenants and evicting their current ones, increased investment by the public and private sector in neighborhood necessities, such as transit, parks, restaurants, grocery stores, etc., in neighborhoods that have historically been denied. Although, as many of us know, often residents from these same neighborhoods have been advocating for these same necessities for years. These are often the same communities that have historically been labeled as risky or unfit for investment, so largely urban communities of color, where there's now a renewed interest in development. Gentrification can also look like changes in land use. So from industrial to high-end restaurants and storefronts, often resulting in changes in both the character and the culture of the neighborhood. So, this is looking like local businesses and NGOs and grassroots organizations who are pushed to the fringes as new businesses are established that cater to the new community's interests and income. For the residents that aren't displaced, those who remain often feel a sense of isolation in their home. Their friends and family have been forced to leave. There's an influx of high-end businesses and restaurants that they can't economically participate in, and their neighborhood is really just no longer a reflection of their home. Gentrification often also looks like an increased police presence. So in order for the new, usually the white residents, to feel safe at the expense of the original residents, which are often folks of color, being further targeted by the police. So before I dive into the health impacts of gentrification, I'm going to start by sharing a story with you. My final year of graduate school, I had the privilege to participate in a research and advocacy project, which partnered with local advocacy organizations, Harbor UCLA, and the residents of Watts. So as some of you may know, Watts is located in South Los Angeles. This is a community with rich culture, vibrancy, and progressive activism dating back to the Civil Rights Movement. It's also a community that has faced decades of oppressive practices, right? Such as disinvestment by the public and private sector, poor urban planning, and high levels of exposure to environmental toxins through contaminated land, air, and water. My role was in the development and analysis of a comprehensive health needs assessment with Jordan Downs. So this is a public housing community of roughly 700 low-income, primarily African-American and Latino residents, most of which are single mothers with children. The goal of our needs assessment was to provide essential data to policymakers, researchers, health expert, and most importantly, the residents of Jordan Downs on the environmental health impacts of Watts with an eye towards policy change. Our health needs assessment covered physical and mental health, housing conditions, and the full spectrum of the social determinants of health. So it is important to know that Jordan Downs ranks as one of the top 5% most socially and environmentally vulnerable communities in the state of California, and that there are nearly 24 cleanup sites within a 1.5-mile radius of Jordan Downs, 5 of which are just adjacent to the community. The housing complex of Jordan Downs also sits on land that previously housed a steel factory, so the remnants of which have resulted in contaminated soil that's laced with arsenic, lead, and other cancer-causing chemicals. Some of the preliminary findings from our needs assessment indicated that 91% of Jordan Downs residents had water coming from their tap that is brown, rust-colored, dirty, or murky. As a result, 95% indicated they don't feel comfortable drinking water from their tap, many of which are forced then to pay out of pocket for filtered or bottled water, which is a huge expense. 67% of residents indicated they had cockroaches in their apartment, 36% had mold, and 53% had rats. We know that living with mold is linked to health problems, right? Such as allergies and asthma, as well as other respiratory issues. And that living with cockroaches and rodents can expose tenants to disease-causing germs and cause gastrointestinal and respiratory infections. Meanwhile, Jordan Downs has been targeted for redevelopment by city leaders and developers whose goal is to create a mixed-income, vibrant urban village with a promise to rebuild Jordan Downs as a community and erect 710 new beautiful apartments and townhomes, 9 acres of green space, a community center, a grocery store, as well as new shops and restaurants. Some of these new apartments are promised by the city to be allocated for current residents without a rent increase. In our experience working with Jordan Downs residents and Watts community members, although some residents are hopeful, several residents have expressed feeling skeptical and uncertain about the impact this will have on both their home and their community. Some residents have expressed that they're definitely not against development. These are things that they've wanted for years, but that as a community that has historically been disinvested from and denied basic necessities, which is exemplified in the preliminary results of our needs assessment, residents are concerned that the development ahead could lead to the displacement of people who've called both Jordan Downs and Watts their home for generations. So I hope at this point it's clear that we really can't talk about gentrification without talking about the systemic conditions, the root causes, and the drivers of gentrification, such as institutional racism, manifesting as urban disinvestment, and the concentration of power and wealth that's resulted in harmful policies and practices. Therefore, we know that gentrification is fundamentally about power. So specifically an imbalance of economic, racial, and political power. We have examples of this right here in Los Angeles in our own backyard. So if we look at the history of the Chavez Ravine and Dodger Stadium, or the vibrant and inspiring Defend Boyle Heights movement, which has emerged out of a renewed interest in the neighborhood by the city and developers after decades of a disinvestment, racial discrimination, substandard housing, and a lack of employment opportunities for long-term residents who've primarily been Mexican immigrants. So as we think about these examples, let's consider the impact that gentrification can have on health. Per the Centers for Disease Control, we know that gentrification disproportionately affects the poor, women, children, the elderly, racial and ethnic minorities, and all of those that live at the intersection of these identities, thereby making these populations at an increased risk for the negative health consequences of gentrification. This includes things like shorter life expectancy, higher rates of cancer, more birth defects, greater infant mortality, higher incidence of asthma, diabetes, and cardiovascular disease. Additionally, increasing evidence in the literature shows that populations impacted by gentrification have increased exposure to cumulative stress. So this leads to sustained allostatic load, which increases the risk of hypertension and cardiovascular disease, and generally weakens the body's immune system and function, what we know in public health as a weathering effect over time. Gentrification also leads to things like poor housing conditions, increased exposure to violence and crime, anxiety and depression, and can result in things like more time spent in traffic and thus longer commutes, as well as disruption of social capital and networks. We're also increasingly seeing that gentrification can lead to homelessness. So in the 2017 annual homelessness assessment report, it revealed an overall uptick in homelessness in the nation's 50 most populous cities. Los Angeles County, which we know is the epicenter of the homeless crisis nationally, currently has an estimated 55,000 homeless individuals. Locally, Venice Family Clinic, a community-based clinic that has deep roots in Los Angeles, has felt the impact of gentrification on their patient population. The providers at Venice Family Clinic have had to resort to going to the streets, the shelters, but also all the way to the Santa Monica Mountains to find their patients. These are patients who used to sleep near the clinic and use it as temporary shelter, waiting to be seen, but have recently been pushed to the margins further due to the influx of high-end restaurants, shops, and homes that now surround the clinic. This has also resulted in increased police presence of the homeless population, and therefore their inability to access the health care services they used to rely on. As Margarita Loaiza, who's a physician for Venice Family Clinic shared, the neighborhood around the clinic is changing, so we have to take the clinic to them. I realize my short presentation is really only the beginning of several conversations we'll be having today about the impact of gentrification on health. I'm going to end with a few suggestions for ways in which we, as public health professionals, future and current healthcare providers, as well as advocates, can think about how we can start work to address gentrification. Before I do so, I will share with you an exciting win. Some of the data collected from our needs assessment survey in Watts was used in support of Assembly Bill 1397, which links housing access to safe and clean drinking water. The bill passed September of this last year. Thank you. So this really is one of several examples, right, that demonstrates the power of public health researchers, organizers, physicians, and residents working together for policy change to address the impacts of gentrification. So currently I'm a public health professional, but I do come from community and campus organizing over the last 17 years. I believe the way that we can make strides in addressing gentrification and have a justice-oriented approach is by educating, agitating, and organizing. I'll share some examples with you about what this looks like in the work that we do. So first and foremost, listening and learning from residents. Often through our training in public health and medicine, we're told we have a lot to teach the communities that we work with, when in fact our work needs to start by listening to and learning from the community to guide our practice. All of our efforts should be focused on ensuring that existing residents have the voice, the options, self-determination, and resources they need to be healthy and really shape the future of their communities. Second, the data that we develop through our research needs to be used in service of communities so they can advocate for policy change on the ground. This looks like public health departments, for example, providing data, research, and analytical skills to document the significance of displacement in the communities they work and the consequences it has. Third, public health departments and professionals can also work alongside other medical institutions, social service institutions, and community partners to advocate for needed policy change, such as tenant protections and rights and preservation of affordable housing. This includes using their power, privilege, and expertise to provide testimony at public meetings. There are also valuable models and paradigms we can refer to in our work to address structural inequities and the impact that they have on health. This includes things like structural competency, which bridges research on the social determinants of health to clinical interventions. This then prepares clinical trainees to act on the systemic causes of health inequities. Another is public health critical race praxis, developed by UCLA's very own Dr. Ford, housed in the School of Public Health. This is an iterative methodology which helps investigators remain attentive to equity while carrying out research, scholarship, and practice. Therefore, it is the task of public health professionals, healthcare providers, and advocates to see our role as allies of residents and use our institutional power to advocate for and protect health and well-being for all. This includes the right to stable, affordable, healthy homes and communities. My hope is that as we listen, learn, and discuss today, we think about how we're going to go back to our various institutions, organizations, and communities and seriously consider how we can use the power we have to influence change. Thank you.